So determining appropriateness. These are the kind of questions you want to ask when you're reviewing the medications. Is the medication related to the terminal illness? What are the goals of care? And that's really important because you won't know those unless you ask the patient. And that's involving the patient indirectly into the IDG planning process. So this needs to be determined at some point in their care, hopefully early on. Do the benefits exceed the burdens of therapy? For some drugs, such as the dementia drugs, proton inhibitors, even stool softeners, the side effects or potential bad things that can happen outweigh any of the good that can come of them. So we also want to know, is this medication on our hospice formulary? Is this a reasonable therapeutic option for the patient at this time? Is the drug palliative or curative? What's the time needed for benefit? That's going to come up and up again. Time to benefit. You want to ask, is the drug palliative or curative? And then again, the time needed to benefit. You're going to hear this topic over and over again because by definition, our patients are terminal. They have less than 6 months to leave. They need a short time to benefit for it to be effective. And lastly, but importantly, so we can all keep in business, is the drug cost effective? So you reviewed the medications in IDG, and it's not enough to just give recommendations or make comments. As a person leading the team or as a physician or nurse or case manager, you want to make sure that these recommendations are executed and an order change, preferably at the time of IDG, so we're sure that it gets done and is documented. These would be for things like a wrong or inappropriate drug, a use without an indication. That happens a lot when patients come from the hospital. They're on a lot of prophylactic or preventative meds that just stay continued when they're discharged. Is there an untreated indication? Does the patient have something that they need a medication for? Are you identifying an actual or potential adverse reaction? Hopefully, we want to avoid this if we possibly can. Duplicate therapy is common. Again, this comes from polypharmacy and multiple providers. The dosage may either be too high or too low, and you can determine this based on your nurse's or physician's assessment of the patient's symptoms. This goes along with, is the duration acceptable? Do they need the drug more frequently or less frequently? Have you identified possible drug interactions? To a certain extent, the system we have in home care, home base, helps you with this. It does require some override because it may be a little too harsh on the drug interaction, listing everything. So we need to be able to individualize this for patient care. Are there changes in the organ system function? And this will happen as the patient gets closer and closer to dying. Are there good adherence and compliance with the medication? Have they been given appropriate directions? And this happens, I think, more often than we know. They're upset, they're learning everything new right at admission, and we're assuming that we've gone over this all, and they know what to take and how to take it and why to take it. That's why it's important that it's reiterated time and time again. And then sometimes they just never get the medication, whether it's the pharmacy doesn't deliver it or their family's not giving it to them for whatever reason. So the pharmaceutical care plan is developed in IDG. At every IDG, you want to ask questions. Ask questions of the team, ask questions to yourself. Does every med in the profile have an associated diagnosis? Does every diagnosis have an associated medication? Are there symptoms that could be a medication side effect? And how is the patient handling all of the meds? Does it fit in with their goals of care? Discontinuing medications. This is important for a couple of reasons. One is we want to do the right thing for the patient. I find often that when patients come to us with polypharmacy and pages and pages of drugs, often when we pare that down to the essentials, they may improve their overall health care. And then in addition, in order to help us offset as a company the cost of covering everything related to all these hospice diagnoses, we're going to have to be more prudent and discontinue medications that are no longer useful or beneficial to the patients. So again, we're talking about things like short life expectancy, the risk-benefit ratio. The patient's families and goals may not match treatment targets. The intent of the treatment, is it consistent with palliative versus cure? And this may involve discussion with the patient's attending physician, especially if they're an oncology patient and have cancer. That sort of palliation versus cure can be a gray line. And if the treatment's not on the plan of care. These are some general categories of medications to discontinue. And we'll go over these when we talk about the formulary, but we will have a list of what we call red flag drugs or prior authorization drugs. Drugs that cost a lot of money and generally have substitutes that are cheaper or more efficacious and can be used in their place. The dementia drugs. Namenda has just recently been shown to not really be effective at all, and its little partner, Aricept, by the time we get the patients in advanced dementia, stage 7C or D, they're no longer thought to be effective anyways. The proton pump inhibitors, the hospitals puts everybody on these, and they generally come out of the hospital with them. You need to assess if the patient needs this GI protection. Do they have GI symptoms, or is it something that we can deceive? Because it does have side effects. It has side effects like C. diff, bone fractures, and hypomagnesemia. And then for ALS, the drug Riluzole, that's usually only beneficial in the first 3 months of the patient's treatment. And we certainly won't be getting patients on our service that early in their disease state. With Diagnoses, a drug commonly used by the elderly population, it's an over-the-counter drug used for a stool softener. If you use it without a stimulant, we say that the drug has all mush and no push. The statin drugs. These are a hard one to pry away from patients. They've been told by their cardiologist, if they don't continue taking these, that their arteries are going to clog up and they'll either have a massive heart attack or a stroke. But by the time they get to us, the time to benefit is too long for it to be of any beneficial use. And studies with AFib, only 0.2% of patients are prevented from getting a CVA in the time period while the patient is on hospice. So it's a relatively low benefit. It's also metabolized in the liver and may interfere with other drug clearance. The bisphosphonates that help protect patients' bones, again, the time to benefit on this is longer, and the drugs are fairly costly. Anticoagulants, a lot of controversy on this. If they're being used acutely for a PE or DVT that's symptomatic, then by all means it should be considered part of the plan of care. Again, if it's being used for AFib or some other less clear chronic conditions, There's other things we have to worry about, like does a patient really want to get stuck every week for weeks while we determine whether their level's right? And also, many of our patients are frail and have a high fall risk and have significant bleeding problems when taking this medication. So there's challenges in discontinuing medications, especially when you're coming to hospice. Some of these are physical dependence. This can be seen with drugs like opioids, beta-adrenergic blocking agents, antihypertensives, and corticosteroids. There's also rebound conditions that you have to be aware of. Some drugs for asthma and seizures, if they're stopped suddenly, the patient may have an exacerbation of these conditions. There's also, and more importantly, it seems when you're trying to talk these patients out of taking the medications, a kind of psychological attachment to them. They feel like they took them for years, they were prescribed for a condition, and if it's being taken away, then they lose a little bit of control. They lose a little bit of that hope of getting better in the future. And also there's clinical inertia. It's hard to talk to patients about discontinuing medication. It takes time. So the path of least resistance is to not talk about it at all and just continue the drugs. And like we said with the psychological attachment, there's that perception that withdrawal of medications is going to equal death for them. So we need to overcome these challenges with really good communication. This is a list of some of the medications that might need tapering. It's not an all-inclusive list, but it does include drugs that we commonly see in hospice. Some of the antidepressants, especially paroxetine and venlafaxine, some of the antipsychotics, baclofen, a muscle relaxer, beta blockers, antiepileptics, clonidine, Xanaflex, corticosteroids, and benzodiazepines. So what are the barriers to communication? There's that sense of abandonment. Already the patient has been referred to hospice, and most times their attending has not followed with them. They are no longer going back to the hospital. Now we're wanting to change their medications. So that's a lot for them to comprehend all at once. So there is the importance of maintaining that relationship with the attending physician, even if they decide not to follow the patient, but want to be kept in the loop. They may help you bridge some of these barriers. There's certain cultural concerns, and this may involve that patients, due to their class or race, feel like they're being denied medications that everyone else gets. The fear of losing control is a big one, and most patients experience this. Their medications put in their tiny little pill boxes Monday through Friday, AM, PM, for years gave them a sense of control over their illness. So without this, they have fear of death, fear of losing hope,